The next section of the female genital tract that we're going to cover is the endometrium and the myometrium. Basically, both of these make up the uterine wall. Remember that the endometrium is the mucosal lining of the uterine cavity, and the myometrium is that smooth muscle that underlies the endometrium. Here's a histologic picture just to remind you of normal. So again, we're going to make a little division here, and we're going to remind ourselves that this is the endometrium, and that's the mucosa that lines the uterine cavity. And then this is the myometrium, and of course the myometrium, as you'll recall from histology, is made up of smooth muscle. Now remember from physiology that the endometrium is hormonally sensitive, and it grows with estrogen, and then gets prepared with progesterone, and then sheds when you remove the progesterone support. So if we wanted to remind ourselves of that, we would just remember that it grows, and then it's prepared, and then it sheds. All right, so remember that there is a proliferative phase during which it grows, and this is driven by estrogen. And then there is a secretory phase in which it is prepared for implantation, and this occurs via progesterone. And then eventually, when there's loss of progesterone support, we get shedding, and shedding occurs, and that results in menstruation. All right, first syndrome that we want to discuss, Asherman syndrome. Now the idea here is that the patients get secondary amenorrhea, and the reason they get secondary amenorrhea is because they lose their basalis, which is the regenerative layer of the endometrium. Now this requires us to go back a step and remind ourselves that when you look at the endometrium histologically, and when you understand the endometrium physiologically, remember that the endometrium grows and produces a functional layer called a functionalis, and then that sheds. And then it grows again and produces a new functionalis, and then that sheds. And then it grows again and then sheds, etc. Now the layer that regenerates that endometrium with each cycle, that's called the basalis. So the basalis is the regenerative layer of the endometrium. It is the stem cells of the endometrium. And by the way, examiners love to ask you where the stem cells are in particular disorders. Now imagine if we had a circumstance in which we lost that basalis. If we lost the basalis, we wouldn't be able to regenerate the endometrium, and if we couldn't regenerate the endometrium, the patients would then get secondary amenorrhea, which would be, a lack of menstrual cycles. Now, what would be the cause of Asherman syndrome and this secondary amenorrhea with loss of the basalis? Well, a common cause is overaggressive DNC. Now, in a DNC, what happens is that let's say a patient needs a DNC and we want to go in there and scrape something out of the uterus. Well, we go in there, literally, we dilate the cervix, and then we curettage or scrape away the surface of the uterine wall. Now imagine if the physician or the person performing the procedure is too aggressive in that scraping away of the uterine wall, they could actually scrape away the basalis, and if you knock out the basalis, there is not going to be the ability to regenerate that endometrium, and therefore the patients will get secondary amenorrhea. So that is a rare but possible complication of DNC, and that's called Asherman syndrome. Again, what's the high yield here? The whole notion of the basalis. That's what's important when understanding the principle of this disease. The next disorder that we're going to talk about is called anovulatory cycle. Now, in this particular case, what happens is the patient goes through a proliferative phase, but they don't ovulate. And remember that once ovulation occurs, that then puts us into the secretory phase of the endometrial cycle, where we prepare the endometrium with progesterone. And so in an anovulatory cycle, there is a lack of ovulation. That lack of ovulation results in a lack of a progesterone-driven secretory phase, and then eventually the patients present with bleeding. And so the idea here is that you've got estrogen, it causes the endometrium to grow, and then you're supposed to have progesterone, which will prepare the endometrium, and then eventually, when it's withdrawn, will make the endometrium shed. But in this particular case, the patient has estrogen and the endometrium grows, and then they don't undergo the progesterone phase. Now, when they continue with their cycle, they're again going to get another estrogen phase, which is going to cause growth of the endometrium on top of the previous growth, which then eventually will result in overgrowth of the blood supply. So the cells will grow beyond the blood supply, and they'll begin to degenerate, and eventually there'll be some bleeding. So that results in dysfunctional uterine bleeding. Now, classically, an anovulatory cycle is seen during menarche and during menopause. And so those are the classic times when there can be abnormalities in bleeding, and there can be irregular bleeding due to an ovulatory cycle. Acute endometritis refers to infection of the endometrium. It's usually bacterial. One of the common causes is retained products of conception. So we deliver the baby, then we deliver the placenta, and let's say a piece of the placenta remains behind. So that could become a nidus for a bacterial infection, which would then result in acute endometritis. The patients will present with fever, abnormal uterine bleeding, and pelvic pain. So these are the classic symptoms, and they all make sense because basically you have inflammation of the uterine body. And when you have inflammation of the uterine body, there's going to be pelvic pain. And then, of course, there's infection, so there'll be fever, and then there'll be some bleeding as well. So these are the key symptoms of acute endometritis. Chronic endometritis is when you have chronic inflammation of the endometrium. What's important to note here is that lymphocytes are normally present in the endometrium. They can be seen in the endometrium, and therefore the characteristic cell is a plasma cell. So you actually have to see a plasma cell in the endometrium in order to call chronic endometritis. So it's a histologic diagnosis. Common causes include retained products of conception, chronic pelvic inflammatory disease, especially chlamydia, for example, can give you a chronic endometritis. An intrauterine device can become secondarily infected and give chronic endometritis. TB would give you chronic endometritis, and in that particular case, of course, we would see granulomas. So we would get granulomas with TB. I think we're all well aware of that. These patients, they present with abnormal uterine bleeding, pelvic pain, and infertility. And infertility is important because I'll tell you that it's common for endometrial biopsies to be done in patients with infertility, and they'll write on the requisition when they submit that biopsy, please check for chronic endometritis. And when they say that, I know that I need to now look for plasma cells in the endometrium because this patient has infertility and they're trying to determine whether chronic endometritis might be a cause of that infertility. The next disorder, endometrial polyp. Endometrial polyp is a hyperplastic protrusion of endometrium, presents with abnormal uterine bleeding. The idea here, this is the endometrial polyp. This is the surface of the endometrium here, but you can clearly see that we've developed this big polyp. Now obviously as this polyp begins to stretch away at the endometrium, that's going to result in bleeding. And so the classic presenting sign of an endometrial polyp is abnormal uterine bleeding. Now, one very important high-yield farm association here is that the patients can actually develop endometrial polyps as a side effect of tamoxifen. A little bit counterintuitive because when you think about tamoxifen, you think about its anti-estrogenic effects, especially in the breast. However, it's important to note that tamoxifen is actually anti-estrogenic on the breast, but it has weak pro-estrogenic effects on the endometrium. And it's those pro-estrogenic effects of tamoxifen that result in the production of an endometrial polyp. This is again the picture of the endometrial polyp, which I've already explained and is present in your text. The next disorder in the text, endometriosis. What is endometriosis? It is the abnormal placement of both endometrial glands and stroma outside of the uterine cavity. Endometrial glands and stroma, and I should actually be more correct in saying outside of the endometrial lining. So when endometrial glands and stroma are misplaced in another location, that's called endometriosis. Now I keep emphasizing this endometrial glands and stroma. It's both. It's both the glands and the stroma of the endometrium that would be misplaced. This is going to present with dysmenorrhea, which is pain during the menstrual cycle, and the reason is because these displaced glands and stroma are going to cycle the same way that the endometrium would cycle, and so that can result in pain, particularly because this tissue is located in an abnormal location. So there'll be dysmenorrhea and pelvic pain. Infertility can also be a consequence of endometriosis, as I'm going to make clear as we move forward in our discussion. So one more thing that I should remind you of, and sometimes examiners like to ask, so what do we believe currently causes endometriosis? Well, there's actually three distinct theories of how endometriosis develops. The first of those theories is called the retrograde menstruation theory, and the idea here is that some menstrual products go backward instead of out, and they go up through the tubes and then eventually can go into the ovary and can eventually go into the pelvis. So that's called the retrograde theory, and that's one way, and that's sort of the leading theory at this point as to how endometriosis develops. The next of the theories is the metaplastic theory, and the idea behind the metaplastic theory is that the Mullerian duct from which the uterine wall, etc., develops, it has the ability to develop into multiple different types of epithelium. So, for example, the cervical epithelium develops from the Mullerian duct, the endometrial epithelium develops from the Mullerian duct, etc. And so there's a metaplastic theory in which it's believed that there's metaplasia or endometrial metaplasia of some of the epithelium, which then results in endometriosis. And there's a third theory, which basically is called the lymphatic dissemination theory, and the idea here is that the endometriosis goes through the lymphatics and then begins to spread to other regions. And the people who argue for that theory, they argue that it's possible to see endometriosis in very strange sites, like for example the lung. So how would endometriosis get to the lung? It must go through the lymphatics. It can't be retrograde because retrograde would not give you access to the lung. Anyway, that's a little bit of theoretical. What's probably most important is to recognize that the current prevailing theory is the retrograde menstruation theory. When you have endometriosis, there are some common sites of involvement. The most common site of involvement is the ovary. And the classic problem within the ovary is called a chocolate cyst. And I'll illustrate that in a few minutes when we get to the next slide. Other places where you can have involvement of the uterine ligaments, which would cause pelvic pain, involvement of the pouch of Douglas, which would give pain with defecation, the bladder wall, which would give pain with urination, the serosa of the bowel, abdominal pain and adhesions, and the fallopian tube can result in scarring. Now, if you involve the fallopian tube with endometriosis, you're going to get some damage and some scarring, and that scarring could then prohibit the egg from reaching from being able to move to the uterine cavity, and so that's going to increase the risk of infertility, and it's also going to increase the risk of ectopic tubal pregnancy, i.e. the implantation of the ovum into the fertilized ovum into a place other than the uterine wall. So these are common sites of involvement. These are some of the complications. I think if you understand a little bit of basic anatomy, it's not hard to understand these classic signs and symptoms. Again, chocolate cyst being the most important of these, and fallopian tube scarring with the subsequent risk for both infertility and for ectopic tubal pregnancy being the second most important on this list. Now here's a picture of a chocolate cyst. This entire thing is the ovary, and you can clearly see that there's this cystic lesion within the ovary, and this cystic lesion is full of this chocolate bloody material. This is just menstrual products basically, which then accumulates as a cyst. So this is called the chocolate cyst of the ovary. Again, let's remind ourselves that if we've got a normal ovary and we get a little bit of endometriosis that implants, what's going to happen is the endometrium is going to grow and shed and grow and shed and grow and shed and grow and shed with each subsequent cycle, and that's going to result in the accumulation of all this bloody debris, which then is going to produce that chocolate cyst. So that's the basic theory there. Now here's another picture. This is involvement of soft tissues by the endometriosis, and the idea here is that we've got all these little brown specks. These are also called gunpowder lesions, and this is what endometriosis looks like when it involves soft tissue. It produces these little hemorrhagic areas, these little brown hemorrhagic areas, which are also called gunpowder lesions, and you need to be familiar with that for examination purposes as well. Now, one very high-yield principle to recognize is that you can actually get endometriosis that involves the myometrium. So remember that you've got the endometrium up here, and then you've got the myometrium here. If you get endometrial glands and stroma that are actually present within the myometrium, that's endometriosis of the myometrium. That gets a special name, and that's called adenomyosis. And you can bet that that term shows up on exams. Adenomyosis is the presence of endometriosis within the myometrium. The adeno here refers to the endometrial glands, and the myo refers to the fact that it's in the muscle. So adenomyosis. You need to know that term. One of the complications of endometriosis, along with the clinical signs and symptoms, is that there is an increased risk for carcinoma at the site of endometriosis, especially the ovary. And this is going to come back a little later in our discussion, so it's nice to bury this away in our minds now. An increased risk of carcinoma at the site of endometriosis, especially when it involves the ovary. Another lesion to be familiar with in the endometrium is called endometrial hyperplasia. This is hyperplasia of the endometrial glands relative to the stroma. Let's illustrate this. Let's pretend that we're looking at this on a slide. Now you'll recognize that when you look at a piece of endometrium, you might see some glands like here and here and here, and then the rest of what is present as white, all of this would actually represent stroma. This is the connective tissue that holds together the endometrium.